Hopefully you had a nice few laps around the lake with Dr. Wright. You burned off your lunch already. You notice this year we didn't give you the huge cookies that we gave you. I know you miss it, but all right. Welcome back. So the session this afternoon, we're now moving a bit into some very exciting advances in treatment of advanced prostate cancer. There have been a number of very exciting thoughts about how we approach this cancer that we've never done before. And our first speaker for this afternoon is Dr. Paul Lang. I'm not sure it's really on very well. Can you hear me now? Got to get right up next to it. Okay. So our first speaker for this afternoon is Dr. Paul Lang, who is the past chair of the Department of Urology at the University of Washington and is the director of the prostate cancer, of the Institute for Prostate Cancer Research. He's made major contributions in the field of prostate cancer, including early development of the PSA screening test. So there have been thoughts really about how we reevaluate the presence of the prostate itself in the setting of metastatic prostate cancer, thinking that that is still the source of many tumor cells that may be spreading. So Dr. Lang is going to give us an update and discussion about how we think about this.
Thank you, Pete. Good afternoon. It's good to see so many, dare I say, old friends. But since I'm now in that category, I guess I can. And at my age, I begin to realize that life is mostly a series of stories. And so I'm going to tell you a few stories, some history, because I think it's pertinent to this topic. And the first thing I'm going to talk to you about is these two people. This is when I was chief resident, and one of my junior residents is Dr. Clayman, who went on to become chair at UC Irvine, did a lot of other things, and was actually dean of UC Irvine for quite a few years. And when we were in this position, prostate cancer was not very common because PSA hadn't been really discovered then. And when we did find a prostate cancer, which was usually fairly advanced often, but when we could operate on them, we did what we called a perineal prostatectomy. In other words, we went in from below because we thought it was less dangerous than going in through the abdomen, and it was in those days, and we just took out the prostate. We didn't even think about lymph nodes, even though cancer biology and many other cancers, they were already doing that. But these two gentlemen developed the lymphadenectomy, taking out the lymph nodes with the prostate, and so we all started to do that. And initially, we took out these lymph nodes, which in retrospect was kind of silly because they were fairly far away from the prostate, and yet the lymph nodes close to the prostate, because they were a little more technically difficult to do and a little more dangerous, we didn't do. Eventually, however, we began to take out more lymph nodes in the so-called extended pelvic lymph node dissection, and we took out the lymph nodes closer to the prostate. And here is the standard lymph node. Actually, it's not that standard. I was already doing something a little more extreme than usual for reasons I'll tell you in a minute. But then, thanks to some of the work we did, but mostly we work in Europe, we then did a bigger lymph node dissection, taking out more lymph nodes. And we did increase to some extent, about 20%, of the patients who had positive lymph nodes. When we took them out, we cured them. Because in those days, and certainly in the early days, if the lymph nodes were positive, that meant that the disease was metastatic. It had already spread beyond the prostate. And at those days, we thought that you had cancer in the prostate, and then it spread to the lymph nodes, and then to the bone, as you know, or it went to the bone directly, bypassing the lymph nodes. And once it did that, the prostate was not really in the conversation, because the cancer had spread to the bone or to the lymph nodes, and then they kept spreading to more bone and to more lymph nodes, and that was in fact the way we thought of cancer. And we said, well, you don't close the barn door once the animals are already outside because it does no good. You don't take out the prostate when the animals have already escaped. So in those days, we said, oh yes, we need to take out the lymph nodes, and we were so stupid to have not done that before, but the radical retropubic prostatectomy was initially a very dangerous operation, but then it became much more common, much more tolerated, and much safer, and as you know, we moved on from the open radical retropubic or abdominal prostatectomy to the one with the robot. But in those days, if the lymph nodes were positive, we stopped. We stopped because the horse and the animals were already in the barn. We then gave hormones or took out the testicles in those days. Later on, we gave shots, as you know, and we did androgen deprivation therapy. And in fact, most of the lymph nodes that we took out were patients that the radiation therapists sent to us because they wanted to know if the lymph nodes were positive also, because if the lymph nodes were positive in their environment, they didn't radiate the patient, they put them on hormones also. If the lymph nodes were negative, then they radiated. But then came what I call the Mayo heresy. At the Mayo Clinic, and then very quickly next door at the University of Minnesota where we were, they began to take out the prostate even if the lymph nodes were positive. And then immediately after, or even at the same time, they did hormone therapy. That is, they took out the testicles. Occasionally, the patients forgot about the fact that they were talked about the orchiectomy, and when they woke up, they not only didn't have a prostate, they didn't have any testicles, and some of them got a little upset about that, but they just weren't listening. And after many years of this heresy, and believe me, it was a heresy, most patients, Hopkins being one, they said that's malpractice. That is not indicated. That's terrible. And I can still remember when I was a visiting professor at one of the institutions, Utah, and I took out the lymph nodes and they were positive, and I took out the prostate. And later on, I was supposed to give that a lecture. They almost didn't want me to give the lecture because I had committed such a heretical act. But many years later, when they published a very large series, almost 1,000 patients, and looking in retrospect, they found out that if they did take out the prostate and then did hormone therapy, that the patients did a lot better than if they did the orchiectomy alone. And very quickly after that, well, not so quickly actually, other groups did the same thing. They looked at patients who, for one reason or another, had their prostate out with positive lymph nodes, and for one reason or another didn't have their prostate out, looked at the differences, and they saw that when you took out the prostate, the patients seemed to do better. So what happened then was that more and more people began to take out the prostate. Even the group at Hopkins joined the heretics and began to do that. Funny thing, when that started to happen, the radiotherapists didn't send us the patients anymore. Maybe because if they sent us the patients, they didn't get them back. We took out the prostate. So business being what it is, they suddenly decided that lymph nodes weren't all that important. Later on, they didn't think they were important and gave hormone therapy with more serious cancers and even extended the radiation beyond the prostate. Now, I've got a confession to make because I came from a heritage which involved these papers. Started out with Wyland Letberer, who was a thoracic and general surgeon in the Second World War, became a urologist and trained these gentlemen, some of which have already expired, but were major leaders in urology and were noted for being rather aggressive, macho surgeons. And one of them was my chief, Dr. Fraley. And so I, in fact, sort of developed that and drank that Kool-Aid and did a lot of things in my career, doing more and more aggressive surgery in various places regarding the prostate. In fact, I even had a lecture, would we cure any more patients if we cut people in half? that was a metaphorical statement, although some people began to wonder. And Dr. Clayman, in fact, was drinking that Kool-Aid, although later on he became famous for actually the father of laparoscopic urologic surgery and even the robot. But I must, despite the Kool-Aid I was drinking, point out some caveats to this aggressive approach. One is these were retrospective studies, and some people were saying we were comparing apples and oranges. The patients that only got the orchiectomy may have been older, may have had health issues, and may have more serious disease, so the surgeon said, well, it wouldn't be worth it. And so this comparison was a problem. We tried, in fact, to do a randomized trial. I wrote the protocol, but NIH said it was not ethical and was not possible. But the radiation therapists, I did change that, but it still came out T. Radiation therapists, in fact, did do the randomized trials. And they did, and I'll show you two of them. And in fact, I think that's the most poignant data we have to suggest that this new approach, which I'm going to talk to you about in a minute, might have validity. And what these studies showed when they took patients who didn't have metastasis, but they kind of did. They were very advanced local disease, so many of them did have positive lymph nodes, though the radiotherapists didn't worry about that. And many of them probably had bone metastasis that we didn't yet see. And when they looked at large numbers of patients and they randomized them into patients who had only hormones versus patients who had hormones plus radiation to the local gland, just like taking it out, destroying the gland, they found significant advantages to destroying the local gland. During this time, before and subsequently, tumor biologists, and I'm not going to go over this slide in great detail, began to realize that in addition to having the metastasis beget other metastasis, and they talked to each other or to the lymph nodes, there was also crosstalk with the primary, with the cancer that was still in, particularly if the prostate were still in, because, say, the man came to see you initially with bone metastasis at diagnosis, or positive lymph nodes that didn't have surgery, et cetera, et cetera. And so data began to accumulate even further that, in fact, a prostate that was left in, if you had metastasis, might, in fact, be contributing to the progression of the disease. And then a couple of studies came out in retrospect, looking at large databases. And one of them I'm very proud of because it involved Dr. Culp, who was one of our residents, now at UVA, and Dr. Shellhammer, my best friend, who you saw last year, who I operated on actually 15 years ago. And they looked back at the data, and when they found the patients, for one reason or another, who had their prostate taken out when they had metastasis, and compared to the patients who didn't have their prostate out, they found a significant difference. Very quickly after that, the group in Europe did the same study with large databases and basically found the same thing. And then they said, well, maybe this is a good idea. And in fact, other cancers seem to have this kind of tendency, taking out the primary when there was already spread was okay. They mention ovarian, and that's true, but ovarian is a little different. It doesn't metastasize much beyond the abdomen. But randomized trials did show that in kidney cancer, if you take out the primary when there's already spread to the lung or bone, the patients seem to do better. They keep mentioning colon, although I think that data is still very controversial. I'm not too sure I believe it. And they even mention breast. And in fact, here is a recent study in which they looked at the studies in which they took out the tumor in the breast in the woman who had a metastasis. And they did, and again, these were not, most of these were not controlled, but it does kind of give you a suggestion, a small suggestion, that taking out the primary in the face of metastasis might be useful. I hasten to mention, however, that while prostate and breast are almost mentioned in the same breath, they're not exactly the same. Indeed, if you look at the screening studies, mammographies over many years, PSA over many years, you find one difference, which in fact is one of the indictments against screening in breast cancer. And that is that even with all this screening, if you look at the patients who have metastasis when they get diagnosed for whatever reason, it hasn't changed during the era of mammography, whereas in prostate, it has plunged significantly, making some of us believe that if you really look at the data for screening in prostate looks actually a little better than mammography. But the task force doesn't have the guts to give mammography a D rating. It has only a C rating. But there's a good reason for that, because the morbidity from overdiagnosis, i.e. radiation, chemotherapy, is thought not to be as worse as the morbidity for prostate, and there's some justification for that. And so in closing, what's happening is that now more and more people are starting to drink a different Kool-Aid. That is, hey, we can take out the primaries, or we need to test whether we can take out the primary or radiate the primary when the patient has metastasis. And this is one trial, mostly in Europe, called the Stampede trial, in which part of it has radiation, with or without radiation is one of the arms. Here's another trial, mainly in the Netherlands, in which they've already accrued all the patients, and again, they're doing radiotherapy. And an NIH trial in which they're doing either radiation or surgery and looking at the results. So this is exciting, particularly to a macho type of surgeon, but I hasten to add that this is still very much a hypothesis. If we take out the primary, that is the primary in an asymptomatic patient, are we going to in fact advantage the subsequent course of that patient? I have to mention that if you're symptomatic, if you have pain, if you can't pee, et cetera, that's a different story, and surgery in that case is often indicated. I think it has a very good chance of helping some people, particularly with small amounts of metastasis, but I have to hasten to add that this is still very experimental, and it should ideally be done in clinical trials. Thank you.
Thank you, Dr. Lang. I'm sure we're going to get questions about that. It's a very important issue that's being proposed through a number of individuals about, again, aggressively treating that local cancer in the setting of spread. So it's a pleasure to introduce Dr. Bruce Montgomery, who's my twin, maybe. Different mothers, but we look alike. So Bruce Montgomery is a professor of medical oncology at the University of Washington. He's really a world expert in the treatment of advanced prostate cancer, and in particular, some of the new subtypes of prostate cancer that have been identified that through targeted biopsies we can understand how best to develop new therapeutics targeting them. So he's going to give you some, really a glimpse into this really exciting area. Bruce?
Okay. Thanks. Can you folks hear me? Get this a little bit closer. How's that? Can you hear me? Great. Okay, so you heard Dr. Lang talk a little bit about telling a series of stories, and that's really what I'm going to do today, because what I'm going to talk about is what's called precision medicine, but it's really what we talk about as personalized medicine. We're not going to talk about big randomized controlled trials. We're going to talk about how we can hypothetically go in and decide what's important in an individual's tumor and what we can do differently about treating that. So in the course of this talk, I'm going to talk a little bit about some of my patients because they participated in a study which I think has changed the face of prostate cancer in any number of ways, and sort of give you an idea of how that information that we gain from an individual cancer can be used in some very specific settings now, but with the idea that we are changing the landscape and the series of things that can be done about prostate cancer in a way that is now unprecedented. So when we talk about sequencing, it's kind of important to understand what that is. So in every single cell, there's DNA, and every DNA genome has 3 billion letters, let's call them nucleotides, okay? So the idea is that when your body turns over a single cell, you have to replicate those 3 billion nucleotides in a way that is exactly the same, okay? So when you do that, it's obviously critical that you avoid making a mistake, because a mistake ends up causing cancer, right? Which I think is obviously what we don't want. So your body has evolved this system of DNA repair so that it senses changes in DNA and then goes in and repairs them about as accurately as it possibly can. And so we have this process called DNA repair, which involves many, many different genes and proteins. Now, when that system goes awry, we get cancer. And when we get these changes in the DNA, those are oftentimes drivers. And finding out what those drivers are is what sequencing is all about. So when we talk about, you hear on TV about many different ways of doing sequencing. So you'll hear about things like whole genome sequencing, which means literally sequencing every base pair in that genome. Okay, that's a lot of DNA, and a lot of that DNA is irrelevant. There's what's called exome. That's the part of the DNA that is turned into protein. So that's, a lot of people are focusing on whole exome sequencing. Most of the commercial assays that you know will hear about are really looking at parts of the genome that we know have some importance in terms of the treatment of the cancer or driving the cancer, so that it's prognostic. And so it gives us information that's important in terms of treatment. So the thing that it really isn't talked about when you hear these sound bites on TV is that not every mutation has any relevance, okay? When a cancer cell is just turning over and it's not able to repair DNA accurately, you get all sorts of mutations that have nothing to do with anything important, okay? Those are called passenger mutations. Driver mutations do something different about the biology of the cancer, or they can predict for a specific therapy being effective or ineffective. And those sorts of things are obviously critical when we're talking about treating somebody. So when we also hear this term actionable mutations. So what that really means is a mutation that you can use, okay? So there are two classes of those. One that is a mutation that we can use today, meaning that there's an FDA-approved therapy either for the disease we're talking about or even another cancer that we can hypothetically get approval to use in, let's say, prostate cancer. Or there's a mutation that might allow somebody to participate in a study looking at research agents, things that are trying to improve outcomes for men, and that's an important association. That is, it's something that might tell you that a drug that's being tested could be more effective. So this is the sort of the money shot of a study that I talked about last year. I'm going to reemphasize it because this study has changed the face of prostate cancer research. This paper gets cited at every single meeting I ever go to about prostate cancer. And we participated. In fact, we put more patients into this study than anybody else. And what it was it's called the Stand Up to Cancer PCF AACR Dream Team effort in prostate cancer. What was done was men who had advanced prostate cancer, meaning metastatic, who had hormone therapy and their hormone therapy wasn't working as well as we wanted anymore. Those folks very generously agreed to participate in a study in which we did a biopsy. And you heard a little bit about biopsies in several earlier talks. As Dr. Nelson mentioned earlier, biopsies, in fact, are not as odious as it sounds like they might be. We have biopsied many, many men, and the number of folks who have had problems is very, very small. So these folks went through this biopsy procedure, and then sequencing was done on the metastasis. And so this is a schematic of all the changes. Now, nobody can look at this and make any sense of it. You have to really, obviously, dig down and say, what are the changes in here that are relevant? So looks like that slide got changed. So the thing that actually came out of this that I'm going to focus on is what's called DNA repair deficiency. So out of these 150 men, and there actually are now 500 men who've been biopsied, but out of the first 150, about 20% of them had these changes in what's called DNA repair pathways, okay? Now there were two classes of these. There's what's called homologous recombination, which is things like BRCA1 and 2, which we know are important in breast and ovarian cancer, and something called ATM. And then there are what are called mismatch repair genes that are important in things like colon cancer, because that's how people inherit a risk for getting colon cancer, is there are changes in these mismatch repair genes. These are also just a different type of DNA repair mechanism. So I've sort of told you my bottom line out of that that slide. But the thing is that what we're looking at is DNA repair deficient tumors. There are potential therapies that I'm going to talk about in just a moment, something called PARP inhibitors. It's not FDA approved yet, but there's a large randomized study that's ongoing, and we can, in fact, get these drugs sometimes if the justification is strong enough. And there are drugs available today, chemotherapy agents that are less toxic than what we oftentimes use and more effective that we could use today. And then the other thing is what are called hypermutated tumors. These are these mismatch repair gene abnormalities, and Dr. Nelson is actually the one who has done most of the work in this, and I'll cite one of his papers in a moment. But the idea is that tumors that have this mismatch repair and are what are called hypermutated, I think actually Dr. Schweitzer mentioned this earlier, have the potential to be targeted by immunotherapy, and I'll show you why we think that's the case in a moment. So this is a story. So this is one of my patients who participated in the Stand Up to Cancer study. So he's a gentleman who had very, very high risk prostate cancer diagnosed back in 2009, was treated with radiation and hormonal therapy. Hormone therapy by itself after the radiation therapy was very effective up until about 2013, and things started to change. So this is a PSA graph of what his PSA did. Now his PSA was relatively low, but these changes in PSA, maybe I can, yeah. So changes in PSA here were reflective of things changing in terms of scans. So somewhere around 2013, PSA started to rise, and we started to use abiraterone, which was not very effective. He then got chemotherapy, docetaxel chemotherapy, which worked pretty well. He then got enzalutamide, which actually did also work for a while, but not for very long. And then he actually participated at this point in the Stand Up to Cancer effort. He had a biopsy done, and we started giving him everything that was FDA approved, cabazitaxel. I gave him docetaxel and carboplatin for a reason I'll talk about in a second. And he came in at this point, and he was miserable. He was in a lot of pain. We'd given him everything that was FDA approved for his situation, and frankly, it was all about, is anything else useful? Or should I just really focus on enjoying the time that I have? That, because we pushed very hard to get the Stand Up to Cancer biopsy results, they came in the day that I had this conversation with him, and he had what's called an ATM mutation in his tumor. So both copies of this gene called ATM were no longer present in his cancer, and that was pretty clearly a driver of his cancer. And as a result of that, we gave him a drug that's an old-time chemotherapy agent that we almost never use to treat prostate cancer anymore, mitoxantrone, because it's a DNA-damaging agent, and this ATM gene is a DNA repair deficiency gene. So the idea was, with mitoxantrone, he went from being so miserable that he could barely get off the exam table to being back, riding his horses, shoeing his horses, doing all that, and that's been the case for the last year. And in the last year, this paper that I'm going to show you in a second came out about a drug called Olaparib, which is a PARP inhibitor. And he just started on the PARP inhibitor a few days, actually a couple of weeks ago, and his PSA has gone from somewhere, again, for him a PSA of 12 means something, and his PSA is down by over half within the first 2 weeks, okay? So that's one example, but that's, this is obviously very important to this gentleman, and participating in this study had a really big impact on his therapy. So I mentioned this, so this is what has happened in the last year since our last IPCR symposium. So this is a paper, this actually, the work that came out of this paper actually was part of that Stand Up to Cancer effort that I showed you the data on. And what was done was, it's been known for a long time that if cancers, mostly breast and ovarian cancer, have DNA repair defects, those cancers become reliant on a pathway that is absolutely dependent on something called PARP. So there were these drugs that were known about, PARP inhibitors, that actually got FDA approved in ovarian cancer within the last year and a half. And so somebody that we all know here, Johann de Bono, did a study where he gave 50 men with just metastatic resistant prostate cancer, PARP inhibitor, and he sequenced their cancers at the same time, looking to see if something in those tumors would predict for response. And in fact, he showed that about 16 of those men did have these DNA repair defects that had been defined in the Stand Up to Cancer set. And in those men, these are the men that had the DNA repair defects, and these are men who did not. And this is how long they basically responded to this PARP inhibitor. So the difference, we talk about hazard ratios for outcomes, and the hazard ratio for this was about 0.2, which is an 80% improved outcome for those men who had this DNA repair deficiency. So this is a huge change in thinking about the biology of prostate cancer, in that a subset, probably 25% of prostate cancers, will have a sensitivity to this drug, which we never thought would be relevant. And in fact, now there are, within the